Dr. Gimbel now showing part 3 of this case of Lenda globus with spontaneous rupture of the posterior capsule during lens removal. We're placing OVD to protect the capsule opening from vitreous herniation and also to create a separation between the iris and the anterior lens capsule to facilitate placement of the 3-piece IOL in the sulcus for anterior optic capture, that Tobias Neuhan termed rhexis fixation. We're enlarging the 2.2 millimeter incision to be able to get the injector right through the incision into the eye to control the exit of the IOL, because these 3-piece lenses, as you go in with the traditional placement of the injector, the haptic is pointing to the right, whereas we want it pointing to the left. So we're going to have to rotate the injector 180 degrees after it's in the eye, adding a little more OVD, because we lose a little as we place the injector through the incision. Now watch the rotation of the injector to get that haptic pointing to the left. And we have to maintain that position long enough for all of the haptic to be in the sulcus and the lens exiting the injector so that it doesn't turn that down forcibly as we rotate back now to get the IOL optic in the proper orientation. Now, rather than just pull the injector out of the eye, I'm going to use a cyclodialysis spatula to engage the haptic-optic junction to stabilize the lens as we pull off the injector. I'm using this spatula now to just lift the optic enough that it's not going to engage the anterior capsule as we place the second haptic and the lens is rotated. The opening in the posterior capsule would make it appear that we've already captured it, but that's triangular opening is the posterior capsule, not the anterior capsule. We have an intact CCC. So for this type of case particularly, it's so critical to get the CCC the right size and as central as possible. The placement of the forceps on the haptic is critical to getting it to rotate and still maintain control. And we're going to add some more OVD. In an elderly person's eye, there usually is not this same posterior pressure, and it's much easier to get these lenses into the sulcus than what we're experiencing in this eye. So there's the second haptic now going into the sulcus. You can see we're trying to maintain the haptic optic junctions in line with the widest opening in the posterior capsule, because often optic capture will engage the posterior as well as the anterior capsule. You can see the proximal part of the optic now being placed under the anterior capsule. And it's deceptive because that ovalizes the CCC, and you have to make sure you're getting both sides under the capsule, or you can leave one side in and one side out. So pushing posteriorly, there we trap it now with the anterior capsule by that posterior pressure, tilting the lens to get the second half of the optic captured. And now we have the CCC ovalized in the same meridian as the posterior capsule opening. I like to have that size opening in the anterior capsule so that we get a very tight capture. Otherwise, when removing the OVD and so forth with the IA, losing anterior chamber pressure, coming out with the IA tip, one can lose the optic capture. But with this tight a capture, it will resist quite a bit of anterior placement of the optic with posterior pressure. You can push down a little. Sometimes the OVD will come around the capture, removing some of it that's in the anterior vitreous. But with this tight a capture, the OVD is pretty well trapped in the posterior segment and does not cause an intraocular pressure spike if there is some retained. But I just push a little bit and at least get what's going to come easily. You can see I injected BSS with the cannula as I took the IA tip out to try to avoid that collapse of the anterior chamber. I'm showing this hydration of the wound because I think that's the most important part of prevention of endophthalmitis, is the very careful sealing of the incisions with stromal hydration as necessary. I like to just massage the lower lip, inside lip of the incision to make sure it's not curled, as you see right there, and hydrating the paracentesis as well. And then testing. I like quite a high pressure to really test the wound. The eye can tolerate a high pressure for just a few moments while we confirm that the incisions are well sealed. And because it might have been possible for some OVD or some vitreous to herniate around as we remove the OVD, I'm using some more Triessence just to confirm that there's no vitreous through the optic capture to an incision. And then We have to now again ensure that the wound is watertight, and it might take a little more hydration again. Again, testing. I like to see the incisions very dry. I use the end of a sponge to press on the eye to test the pressure. Now this is the addition of a little vancomycin in the anterior segment, and again checking the pressure.